I'll also be talking at this World Congress of Melanoma EADO meeting in a debate about the abscopal effect. And there will be, of course, two sides to the debate. And my side is against the benefit of the abscopal effect. And I would certainly concede that there are extensive murine data suggesting that if you take a mouse model of a either PD-1 sensitive or moderately sensitive tumor, and that tumor becomes resistant to PD-1, and then you radiate it, either completely or partially, you can then see a spontaneous regression of distant unirradiated disease, even in the absence of giving further PD-1, or sometimes with further PD-1 when you know it's been resistant. So I absolutely agree. The so-called abscopal effect, which, by the way, was defined many years ago as a radiation-induced effect, where if you have multiple tumors in your body and you radiate one, you then get regression at a distant site, which, to be honest, in radiation oncology is a rare but real phenomenon, maybe 1 in 100. In 2012, Mike Postow published a nice vignette, a nice article in New England Journal, suggesting that in a patient who is on, I believe, ipilimumab, they progressed, stopped the ipilimumab and got radiated to I believe it was a chest wall lesion. And they then had subsequent regression of other disease, along with some very interesting immunologic observations that you had epitope spreading with increased T-cell reactivity in the peripheral blood. That article was very high impact, and it provoked a storm of radiotherapy in patients with melanoma and even other cancers who were on immunotherapy to try to overcome immune resistance and get action at a distance away from the radiated site. There have been a number of randomized studies, which I will discuss, none of which are very large studies, but all of which have 30 to 100 patients, where there's really no concrete evidence that there's a difference between giving immunotherapy with radiation versus immunotherapy alone, or chemoradiation versus chemoradiation with the addition of immunotherapy. So if you put all the data together, admittedly from diverse studies, moderate size, nothing bigger than 120 patients, I struggle to find any evidence that the response rate, PFS, and survival in general are different between giving immunotherapy and then giving immunotherapy and radiating an isolated lesion. So I think the likelihood that the abscopal effect, as we conceive it, that is radiating a site or a couple of sites in a patient resistant to immunotherapy, will then make them more sensitive at a distant site. I think that's not going to turn out to be the truth. And I think that all of these studies are going to end up being negative, the randomized studies of radiation immunotherapy versus immunotherapy alone, or chemoimmuno versus chemoimmuno plus radiation. And I think we just need to move on. And while I concede that every once in a while a patient benefits from radiation to provoke an abscopal effect, and that mice tend to see it, we're not treating mice, we're treating patients, humans. And I think we need to move on and think about other ways of overcoming resistance to immunotherapy.